Medical Patient Modesty is a 501c3 nonprofit organization that works to educate patients about how to stand up for their rights to same-gender medical personnel for certain procedures. We also educate patients and medical personnel about reducing unnecessary intimate exams and unnecessary exposure. For example, patients should be able to wear 100% cotton underwear for surgeries such as knee or hand, which do not involve the genitals. Many patients and medical professionals are not aware that colonoscopy patients can wear special colonoscopy shorts or even boxer shorts turned backwards, only exposing the buttocks. We also educate people about preventing sexual abuse by medical professionals. Please check out our educational website showcasing sexual misconduct by doctors, sexualmisconductbydoctors.com. The website also includes articles about certain doctors as well as other medical professionals who have allegedly committed sexual misconduct according to news articles. Medical Patient Modesty has brochures educating men about their right to modesty in medical settings. This is an important issue because some men have avoided medical care due to modesty concerns and previous bad experiences. We are seeking volunteers to distribute these brochures in different communities. We also need financial support to print more. Go to our website at patientmodesty.org and look for the link Brochures About Men and Modesty. Additionally, Medical Patient Modesty has booklets educating women about protecting themselves in medical settings, with tips to prevent sexual abuse and modesty violations. The medical industry has become very gender and moral neutral. Patients need safeguarding. In society, women and girls are specifically given tips to protect themselves from sexual abuse, but rarely about preventing sexual abuse in medical settings. Sexual abuse in medical settings is more common than many people realize. We need to reach out to as many women as possible with this booklet. We are also seeking volunteers to distribute booklets to women, especially in college communities. We need financial support to print more booklets. Go to our website at patientmodesty.org and look for the link Booklets About How Women Can Protect Themselves in Medical Settings. Here is our GoFundMe page to raise money to distribute more booklets. GoFundMe.com/protectwomeninmedicalsettings.
Surgeons, nurses, and other medical professionals rarely talk about patients' modesty for procedures. However, with the proper communication and education, that patient can have maximum modesty for many procedures. For example, during a colonoscopy procedure, specially designed shorts can be worn exposing only part of the buttocks. A patient could also wear boxer shorts backwards. Also, a male patient could wear a jock strap to secure his male organs. You can see an example of what a colonoscopy short looks like by going to our article, Concerns About Modesty During Colonoscopy, under the Modesty Concerns section at www.patientmodesty.org/colonoscopymodesty.aspx. This article provides information about what steps you can take to ensure you have maximum modesty for colonoscopy. It is the doctors and their assistants' job to make the patient feel as comfortable as possible. Medical professionals often skip over details of the procedure and/or try to make the procedure sound as clinical as possible. In that effort, many times patients are not told about prepping or positioning for surgery and during surgery, or what parts of their bodies might be exposed. Maintaining modesty in these instances is paramount for the patient's well-being. Wearing underwear and/or a bra for women can effectively ensure this modesty, especially if routine surgical procedure is for the patient to be stripped naked, such as during shoulder surgery. It is possible for a woman to wear a specialized bra that covers the breasts but allows full access of the shoulder being operated on. One Illinois orthopedic surgeon invented a special bra for his female shoulder surgery patients after he received concerns from his own employee, who felt uncomfortable letting him operate on her shoulder due to exposure of her breasts. We appreciate surgeons who go the extra mile like this Illinois surgeon to ensure that their patients have modesty during surgery. Look up Modesty patient wear on Google to check out the Modesty bra that women can wear for many surgeries that do not involve the need for access to their breasts. At some hospitals, once the patient is in the operating room, his or her gown will be removed or pulled up depending on what parts of the body are being operated on.
If a patient does not have surgery shorts or underwear on under his or her gown, the genitals will likely be exposed for these surgeries. Exception: knee replacement surgery.
The reality is most surgery patients do not have the whole picture of what may have happened to them and how their private parts may have been exposed. The medical industry tries to indoctrinate many of us to focus only on how well the surgery went. Medical professionals rarely tell us about our modesty and who all saw our private parts as we were being prepped for surgery and during surgery. Most patients under anesthesia never meet all of the people that were present for their surgery because some of those people came in the operating room after they were put to sleep. A female lobectomy patient in Florida who had early-stage lung cancer selected a thoracic surgeon recommended by a top cancer center because of the surgeon's robotic surgery expertise. He has much experience in this specific area and is considered by the medical community as one of the most qualified thoracic surgeon in Florida for robotic lung cancer surgery. This lady had a horrible experience with him. He and his staff, as well as the surgical facility staff, were all very callous when she asked questions and expressed concerns about her modesty and operating room information. She ended up being stripped naked for the surgery. She should have been able to wear underwear or disposable underwear such as Depends. She also did not need a urinary catheter for the surgery. After the operation, when this patient experienced medical trauma and PTSD, as well as severe drug reactions, she talked with the surgeon about all this, as well as going into the operation being completely uneducated and unprepared, facing a life-threatening illness. And this doctor told her that most patients would be happy to be in her position with her diagnosis, and she was one patient who had a problem. Even after the operation, nothing was explained about the patient's concerns, having seen herself naked, completely uncovered and undressed, and freezing both before the operation while being prepped and immediately after the operation when awoken naked and freezing, as well as experiencing hypothermia afterwards in recovery. This surgeon seems concerned only for himself. Compassion did not play a part in this patient's scenario, and because of his and his staff's lack of empathy and help, who knows how this surgeon reacted to other patients' questions and concerns. This indifferent treatment is typical of many surgeons. They just want you to trust their expertise. This surgeon has gotten good reviews from patients who likely have no idea how exposed they were during surgery. There are many skilled surgeons, but the truth is many of them do not care about the dignity of patients, and especially once the patient is under anesthesia, even telling the patient it doesn't matter what happens during anesthesia since the patient is totally unaware.
Sadly, many people are completely unaware that their bodies are unnecessarily exposed for surgeries. Surgeries which don't even involve the patient's private parts. Some medical facilities routinely require patients to remove their underwear for all surgeries. This is ridiculous. For example, think about a patient who wears no underwear under his or her gown for knee surgery. When the gown is lifted, the genitals are exposed. Some patients are stripped naked for surgeries involving a finger, hand, arm, etc. Some surgery patients found out because they woke up naked before medical professionals could redress them. A nurse who worked in surgery for many years made this confession a number of years ago. They will wait until you are asleep to remove your gown and place the catheter, and when you wake up, you'll have that gown back on like nothing ever happened. A number of surgery centers and hospitals across the United States, as well in other countries, have routine policies requiring that patients remove underwear for all surgeries, even if they do not involve the groin area or genitals. This ritual has been practiced for umpteen years. Originally, it was an operating room tradition, seemingly without clear medical indication. Fortunately, as of 2019, some hospitals have changed these policies and now allow patients to wear 100% cotton underwear during many surgeries. One hospital's example of this type of policy allowing underwear states, only 100% cotton underwear is permitted. No nylon underwear will be allowed. The routine removal of patients' underwear was first introduced when nylon underwear could potentially cause static electricity. An author, Brown, in the article, Behavior and Rituals in the Operating Theater, describes the ritual of making patients coming to the operating theater remove their underwear as the most illogical of rituals. It is still practiced in many surgical units and should be stopped for the good reason that it causes embarrassment to the patient and serves no useful purpose. It has been traditional for patients to put on clean clothing and in some units to remove underwear on the ward before being taken to the operating theater. Any risk of infection from airborne bacteria spread from socially clean clothing is unlikely to be large because in comparison with the operating team, little patient movement occurs during operations, thus reducing dispersal of microorganisms from skin and clothing. Here are some arguments medical professionals may use about removing underwear for surgery and how you can respond. 1. We may need to insert a urinary catheter. Urinary catheter is rarely needed for most surgeries that only take a few hours. 2. Underwear could become stained by prep and body fluids. Most patients do not care about this and would prefer to have their underwear stained than sacrifice modesty. 3. Underwear could have metals in them. Most underwear does not have metals in them. Patients could simply wear 100% cotton underwear with no metals or disposable underwear. 4. Need for antiseptic cleaning of the groin. This is not relevant unless the groin is in the operative field. Patients routinely cleanse their entire body with sterile type solution 2 to 3 times before surgery. 5. We need immediate emergency access to femoral vessels in case of emergencies. Underwear can be removed quickly if necessary. There is a minimal percentage of this happening. 6. No underwear helps to maintain a sterile environment. The operating room is not as sterile as the medical profession claims. If the no underwear policy helped maintain a sterile environment, doctors and nurses should not wear underwear either. Medical professionals often carry more germs than the surgery patient because of restroom breaks as well as interactions with numerous other patients, all without changing scrubs in between. Most infections that happen as a result of surgeries are due to medical professionals not washing their hands and bringing germs into the operating room.
We have received stories of some very heartbreaking cases. One lady who had hand surgery woke up naked before they were able to put the gown back on. There was no reason for her to be naked. She could have easily worn underwear, shorts, and bra with no metals for this kind of surgery. It would have been best if she could have opted for local or regional anesthesia and not general anesthesia. Patients should be allowed to wear 100% cotton underwear or disposable underwear for all surgeries that do not involve genitals, such as a lobectomy, knee replacement surgery, etc. Patients that have to undergo hip surgery, cardiac catheterizations in the groin, cardiac bypass surgery, and other surgeries that require access to the groin are encouraged to check out the Dignity garments invented by an orthopedic surgeon at Cover Medical that cover their genitals. All patients should write on their consent form that they do not allow removal of underwear for surgeries which do not involve the genitals, and request a copy of the consent form with the surgeon's signature. Patients need to stand up and break this ridiculous operating room tradition, which violates patients' modesty. If your hospital still has a policy that requires you to remove your underwear for all surgeries, you should consider starting a petition at your hospital to end this outdated policy. Go to our website and look for the link that says Sample Petition at the end of the Unnecessary Underwear Removal for Surgeries. When a patient is under general anesthesia and/or does not have a personal advocate present, such as a spouse, it is very common for medical professionals to ignore patients' wishes for a same-gender medical team for surgeries. Multiple medical professionals representing a gender different than the patient's gender are often brought into the operating room while the patient is under general anesthesia and his or her private parts are exposed. There have been some cases when patients were deceived by medical professionals that their wishes would be honored and weren't. This is unethical. Some examples include removing a patient's underwear and gown while under anesthesia and then redressing him or her before they wake up, promising a patient a same-gender medical team and then not honoring that. A patient can often find out if his or her wishes for a same-gender team were respected by getting an operative report after the surgery. This report lists all people: surgeon, anesthesiologist, circulating nurse, medical student, etc., who were present for the surgery. Also, look at the facility's patient bill of rights to learn what rights patients have. One right is know the names, positions, and functions of any hospital staff involved in the surgery and hospital care and refuse their treatment, examination, or observation. This means that a patient can refuse opposite-sex medical professionals or even intimate exams. It is common for surgeons to arrive after patients have been prepped, draped, and readied. Sometimes surgeons do multiple procedures a day, one after another, and they don't pay specific attention to prep procedures. They depend on the operating room staff to handle that. A patient may make his or her wishes known to a surgeon, and that surgeon may agree with that patient keeping his or her underwear on, for example. But then this request is never communicated to the operating room staff. Therefore, when the patient arrives for surgery prep, if nothing is in writing, their conversation with the surgeon is often forgotten. The operating room staff then proceeds to prep the vulnerable and scared patient as usual. This is why we recommend that a patient get a surgery agreement in writing, and also that a personal advocate be present in pre-op, surgery, and post-op to advocate for all that patient's rights and requests. Keep in mind that the surgeon will be busy operating and may not pay attention to who will be on the operating room team. Often, the hospital assigns the surgery team rather than the surgeon choosing it.
Here's a picture of a man undergoing arm surgery who is apparently not allowed to wear underwear or surgery shorts. We find this a ridiculous requirement for non-genital surgery. Notice that a gown on the man has been removed and placed over his genitals to cover them. This man most likely had no idea this happened, that his genitals were exposed as the gown was removed. Medical professionals often challenge patients who are concerned about their modesty during surgery and try to minimize patient concerns by withholding information about what really happens during surgery. Here are some examples of violations that happen to patients under anesthesia. 1. Spine surgeon who took pictures of a man's genitals with his cell phone. 2. An older male gynecologist making derogatory comments in front of a medical student about a female patient's genitals as he was cleansing and prepping her genitals for a vaginal hysterectomy. This incident was published in the Annals of Medicine, a top medical journal. 3. A sedated female patient was raped during a colonoscopy in Oregon. There was one female nurse present for a colonoscopy, but it did not prevent the rape. 4. Horrified visitors catch sight of surgeons operating on a naked patient after blinds are left open at a hospital. Here are some arguments by medical professionals and our rebuttals. 1. Degrees of nudity occur in most major surgeries, but the exposure does not last long with prompt covering, and during surgery, the patient is fully covered. Our rebuttal is many patients do not want to be exposed even for a few seconds. There are some surgeries that do require exposure of genitals such as hernia, gynecological, urological, etc. But there is absolutely no reason for patients to be routinely required to take off underwear for many surgeries. In fact, some hospitals have started allowing patients to wear 100% cotton underwear for certain surgeries. Here's an example for the doctor who argued that a patient being exposed for a minimal amount of time is okay. Let's say you are showering for work thinking no one is home. You get out of the shower to find out you forgot a towel and walk out naked to get one. And your female neighbor who has come to see your wife is sitting there. You then make a hasty retreat to the bathroom. Does the brevity of your exposure make it not embarrassing or uncomfortable? There are so many justifications, such as, it is brief, we are professionals, we are used to it, or it is no different than an arm to us. Those justifications are ridiculous. 2. A patient's modesty does not matter while they are under anesthesia during surgery because that patient won't know what happened. Our rebuttal is many people feel their body is sacred even when they are asleep.
If this warped surgery modesty mindset were true, why then is it not okay for a male next-door neighbor to view his female neighbor's nude body while she is asleep? Also, this argument that modesty doesn't matter when a person is under anesthesia would mean that all crimes committed while someone is attacked while unconscious, such as with a date rape, drugs, would also not matter because the victim was unaware of what actually happened. These arguments are, if carried out to their indicated conclusions, ridiculous.
3. We need access to your groin for any surgery in case there's an emergency. The groin, which can be dirty with bacteria, needs to be scrubbed with antiseptic before the area is covered. Our rebuttal is underwear or shorts can be removed easily and quickly if there is any surgery emergency. Patients can scrub their groin area with antiseptic before surgery. In most surgeries, the groin will never need to be accessed. Patients should be able to do as much as possible to prepare for surgery so they do not have to worry about their modesty.
Many patients are rushed into signing consent forms without adequately reading them. Also, most surgery consent forms do not give details about many surgery factors. For example, there is no known consent form for a urinary catheterization for surgery. Patients must write on surgery consent forms that no urinary catheter may be inserted. All patients should get consent forms at least 1 day before the surgery. It is difficult for patients to object to anything if they are given consent forms at the last minute. Patients who are sedated or under general anesthesia are entirely vulnerable because they cannot willingly speak up for themselves, which is why we advocate for a personal advocate not employed by the hospital to be present during surgery to advocate for the patient's wishes.
Less use of general anesthesia and more regional and local anesthesia will be significant for patient modesty issues because medical professionals will not have as much occasion to expose patients who are awake and alert. We recommend that all surgery patients consider opting for local or regional anesthesia instead of general anesthesia for most surgeries, thus ensuring less patient vulnerability and modesty violations. Medical professionals will have less chance to expose patients unnecessarily or ignore patients' wishes if the patient is awake and alert. Also, there are generally less complications and a quicker recovery time with regional anesthesia. Surgery patients who plan on utilizing general anesthesia should contemplate having a personal advocate not employed by the hospital present for that surgery to ensure that requests are not ignored. Insist that they do not give you an IV until you have been prepped for surgery so you can observe all the things they do to you before surgery, such as cleansing your abdomen or even genitals, for certain surgeries such as hysterectomy, prostatectomy, etc., and positioning for surgery. One man who underwent hernia repair surgery shared that he vaguely remembered that a woman shaved him. This likely happened as he was being put to sleep. Look at this picture of a woman undergoing a gynecological surgery and the lithotomy position she is in. Her legs are in stirrups with her genitals exposed to the female doctor who is performing the surgery. There's a blue surgical drape over her legs and knees. It's encouraging that all of the medical personnel in this picture are females. But for many gynecological surgeries, there is at least one male medical personnel present unless the surgery patient's wishes for an all-female team has been honored. Patients are often put in a lithotomy position for urologic, gynecologic, and proctologic procedures. It involves lying on your back with your legs flexed 90 degrees at your hips. Your knees will be bent at 70 to 90 degrees, and the padded footrest attached to the table will support your legs. One man from Maine who decided he wanted to undergo a procedure, urolift, for benign prostatic hyperplasia, also known as enlarged prostate, knew that he did not want to be put under general anesthesia because there was a zero modesty with a lithotomy position under general anesthesia, since the operating room would be full of many people, including female medical personnel. Most urologists do the urolift procedure under general anesthesia, so this man did some research. He found a urologist in Utah who was one of the few doctors who did the procedure in the office under local anesthesia. The man flew from Maine to Utah for the procedure and shared it was worth going all the way to Utah. This urologist was very sensitive to the male patient's modesty because he arranged for a male physician's assistant to assist in the procedure. Many urologists often use female nurses or assistants to assist with male intimate procedures. Dr. Stephen Cohen, a professor of anesthesiology at critical care medicine at Johns Hopkins University School of Medicine, says that while many physicians may use sedation in a sincere effort to make the procedure less traumatic for the patients, there is also a perverse financial incentive to use it. Unfortunately, medicine in many places has become a business. The fact is, you get paid more money to do the procedure with sedation, he says. The cost of anesthesia can be more than the fee for the procedure itself, and patients are getting harmed. It is interesting that there is a financial incentive for sedation. Notice the picture of a woman watching her doctors operate on her wrist from going under the knife, with eyes and ears wide open, on New York Times on March 25, 2017. She was able to drive herself home after the wrist surgery because she was not under general anesthesia. Another man in this article had knee replacement surgery with nerve blocks and was able to read a magazine while he was being operated on. This shows that regional anesthesia has fewer complications than general anesthesia and is less expensive. Recovery time is swifter, and side effects are fewer, which can reduce the need for post-operative opioids. Surgery is a multi-billion-dollar industry. Many surgeons and hospitals are driven by monetary gain. Patients should fight to have modesty wishes before, during, and after surgery accommodated. Surgery is a big moneymaker for hospitals. These facilities will give in to patient modesty demands if patients stick together and demand these choices. Canceling surgery is another option if patients' wishes for modesty are not being honored.
Walk out and cancel the surgery if your wishes will not be honored. find another hospital and/or doctor willing to accommodate those wishes. Also, research surgery alternatives and make sure that that specific surgery is absolutely necessary before moving forward with it, and make it clear that you do not consent to Versed, a terrible sedative drug that causes amnesia. Now we are going to discuss why every patient should have the option of a personal advocate, such as a spouse or other person not employed by the hospital, to be present for surgeries or procedures where that patient may be sedated or under general anesthesia. All patients should consider having a personal advocate present in surgery. The advocate could be a spouse, family member, friend, or a medical professional not employed by the hospital where the procedure is taking place. The advocate would be present in pre-op, surgery, and post-op. Patients who are sedated or under anesthesia are totally vulnerable. A personal advocate would help to keep the surgical team accountable in many instances, including not allowing the team to ignore patients' wishes for modesty, as well as protecting a patient's wishes regarding allowing only same-sex personnel to be present for the surgery. With any surgery, the doctors, nurses, and medical personnel enter into an agreement with the patient. An advocate would maintain those preferences and not allow any deviances from the agreement unless medically necessary. A husband in San Antonio told a male scrub technician he could not come into the operating room with his wife, who was having a C-section, and the technician followed his request.
Having an advocate present would also help to cut down on medical mistakes, sexual abuse, and deaths, because the surgical team would be observed by a personal advocate. The patient advocate could also require that the medical professionals wash their hands in front of him or her to help decrease infections. Many hospital-acquired infections are caused by medical professionals not properly washing their hands. Another instance where an advocate present in surgery would be invaluable is when a specific doctor is replaced, because of umpteen reasons, by another doctor. For example, a patient was scheduled to have a more experienced surgeon to do a balloon angioplasty of peripheral arteries in her legs, but for some reason, an inexperienced surgeon substituted him and operated on the patient instead. The patient bled to death because one of her main arteries ruptured. A nurse who was present in the operating room told the patient's daughter what happened, but would not testify against the doctor, perhaps due to the possibility of losing her job. The surgery outcome could have been different if the patient's daughter had been her advocate, been present during surgery, and been able to protest the change of the surgeon. It is ridiculous that many medical facilities have policies prohibiting one family member or a friend from being present for patients' surgeries. Many facilities use the excuse, "We cannot let you in because of germs." But then they let various people, such as medical students and/or non-medical professionals, such as janitor or sales rep, come into the operating room carrying germs. Notice that there is a woman, not in scrubs, laughing in the operating room in this picture. For many years, husbands were not allowed in the delivery room with their wife. Women and husbands actually had to fight to change hospital policies to allow husbands in delivery rooms. In the 1950s and 1960s, men succeeded in being allowed in labor rooms with their wife. Here, alone together, couples shared intimate moments, holding hands, reading together out loud, playing cards. Husbands often rubbed their wife's back during contractions. In the 1970s, hospitals and physicians gradually relented and permitted men to be in the delivery rooms, where they were positioned at the head of the table and could encourage laboring women in their work. The men were happy to be there. With women's encouragement, men continued to press for change in hospital policies and practices. Even so, some fathers felt out of place in a delivery room, which remained medical territory. In the 1970s and 1980s, bowing to couples, albeit consumers' wishes, hospitals opened birthing rooms and combined labor rooms with delivery rooms. All were decorated more like home bedrooms rather than operating rooms. We need to fight against hospital policies that discourage and or forbid a family member or another person the patient chooses from being present during surgeries. Choosing to have a personal advocate present during any surgery should be the right of every patient. For example, a C-section is major surgery. To be present, husbands are asked to put on scrubs and shoe coverings for the wife's procedure. These same requirements could be followed for other surgeries and procedures. Here are a couple of arguments by medical professionals about why you cannot have a family member in the operating room and our rebuttals. 1. Will my family be allowed in the operating room? One hospital policy says, no, in order to maintain the highest level of sterility in the surgical environment, this is not allowed. Here is our rebuttal. This is misguided. After all, we should be more concerned about medical professionals having germs rather than an outside advocate who could easily shower with sterile solution and put on scrubs. Why are janitors, medical students, and sales representatives who may be dirty allowed in the operating room? Many have handled other patients prior to that particular patient. Sometimes, doctors and nurses will take a break during surgery and then return. Also, many surgical staff members eat in the hospital cafeteria throughout the day, wearing the same scrubs. Think about how the cafeteria is full of germs and how these same surgical personnel could bring germs to the operating room. Another issue to consider is that many surgery staff members take bathroom breaks. How unsterile is a hospital's restroom? Every time a person flushes a toilet with an open lid, bacteria spray into the air from the toilet. Most toilets in public restrooms do not have lids. Most nurses are not told that flushing a toilet can spread germs. Maintaining a sterile operating room does not hinge on forbidding a patient to have his or her advocate present during surgery. Generally, having more people in the operating room produces more germs. 2. I would caution those who are unsophisticated in an operating room environment, such as a family member as an advocate, to be present during the patient's surgery, since a vasovagal reaction, such as fainting from observing what was going on, will cause them to become a second patient, needing attention or provide, by making verbal complaints at the time, perhaps a disruption that should be routine procedure. One doctor's argument. Here is our rebuttal. There are some family members who could handle blood in surgery. Any patient can find out surgery and operating room information and then determine who would be a good personal advocate. For example, if a husband does not handle blood well, it probably would be best for his wife to have a friend who can better handle the operating room setting be her advocate instead. Or maybe the patient can hire a male or female nurse from another hospital to be his or her personal advocate. It is very important to have advocates present for surgeries to make sure the patient's wishes are honored. Surgery patients who are sedated or under anesthesia cannot speak up and advocate for themselves. One of the main reasons hospitals do not want family members to be present for surgeries is because they do not want them to see any medical mistakes which may occur. This is provider-centered healthcare rather than patient-centered healthcare. A patient may be promised that his or her underwear will not be removed, but once the patient is under anesthesia, the medical personnel could remove the underwear regardless, since the patient cannot speak up. Medical malpractice suits are very difficult to win because only medical professionals are present during surgeries. Most medical professionals are not willing to testify against a negligent medical professional.
A woman from Minnesota required a hysterectomy, but she did not want to be put under general anesthesia, and she wanted to be 100% guaranteed that she would have an all-female surgery team. Also, that her husband could be present for her surgery. This patient was upset when her first female gynecologist said those wishes could not be accommodated. She decided to find another gynecologist. She shared her view with medical patient Modesty. My husband found medical patient Modesty after I decided to walk out of the first doctor's office, and it gave us the positive motivation to look for the right doctor. My husband kept researching doctors and found one he was sure was a good doctor, then called the doctor for me. During our first meeting, I actually felt comfortable with this doctor. She was so confident and answered everything in straightforward, frank terms. She guaranteed me an all-female staff. After consulting with hospital management and anesthesia, they agreed to allow my husband into the operating room. The staff respected my wishes. I was allowed to keep my gown on. They covered the windows, and no males other than my husband were allowed in. I would never have gone through the operation if it were not for finding this one remarkable doctor who had both compassion and was a master of the healing arts. She didn't put me through unnecessary exams. The Minnesota hysterectomy patient scenario, explaining how a female patient was allowed to have her husband present for her hysterectomy, shows that we as medical care consumers can fight to have our chosen personal advocate protect us during surgery. Surgery is a big moneymaker for hospitals. These facilities will give in to demands if patients stick together and demand those choices. For those people who are passionate about having a personal advocate present for surgery, consider starting a petition at your hospital which allows each patient to have his or her choice of an advocate present during surgeries. You can go to our article, Why You Should Have a Personal Advocate for Surgery, on our website to download a sample petition to use. Medical patient Modesty would love to hear from people who have successfully championed to have personal advocates present for their surgeries, similar to the hysterectomy patient from Minnesota. Please email us at info@patientmodesty.org.
Modern medicine is gender neutral, which means that providers, nurses, and assistants are equally able to offer the services to all patients, no matter the genders involved. While it may be true that mechanics of medical care can be provided by either gender to patients of either gender, there are two important issues hospital administration should consider if patient-centered care is truly a priority. One, many patients have gender preferences, particularly for intimate care. Two, the potential for abuse during intimate care is great, particularly when patients are compromised by medication, anesthesia, or by their physical condition. Many patients and family members are unaware about how gender-neutral hospitals have become until they or a loved one is hospitalized. Today, it is very common for a male nurse, for example, to give a female patient a bath or to administer intimate procedures such as a urinary catheterization or vaginal prep for surgery without the patient's or family's knowledge or consent. Male patients also endure intimate care for female nurses against their wishes. It is hard for a patient or his or her family to object, especially if the patient is in critical condition. Here's an example. One husband in New York did not feel he could speak up at first when some male nurses and techs helped to undress and bathe his wife, who had endocarditis, a life-threatening heart valve infection that almost killed her. A male nurse washed his wife's genitals because she had a horrible yeast infection due to the antibiotics she was receiving. The husband was so focused on her survival because the surgeon said it would be a week before they would know if she would survive. It's sad about how patients who are on the verge of possibly death have to worry about abuse and modesty violations. Many women and their husbands assume that a female patient will always have a female nurse or nursing assistant to help with dressing or bathing when necessary. This was the case decades ago, but things have changed today, with modern medicine becoming increasingly gender neutral. Some labor and delivery and gynecology departments at hospitals have a policy prohibiting male nurses. This is very wise because many women would be very upset about having male nurses involved in their care. Allowing male nurses in those departments pose a high risk because of the potential for sexual abuse. The birth of a child should be a joyful time, and a woman should not have to worry about the possibility that a male nurse would do intimate care for her during this time. Sadly, some hospitals have caved in and let male nurses or surgical technicians in labor and delivery units and gynecology departments over the past few years. They often use this argument: we cannot discriminate when a male nurse wants to apply here. The truth is, it is not discrimination when a labor and delivery or gynecology department does not hire a male nurse, as long as they encourage the male nurse to apply in other departments at the hospital or urology clinics. There is a need for male nurses in other departments, especially urology. In fact, we have many men who have complained there are not enough male nurses. Many men value their modesty. Bona fide occupational qualifications allow employers to hire individuals based on their age, sex, race, national origin, or religion if these specific qualifications are considered essential to the job or considered vital to the business operation. Bona fide occupational qualification can be utilized to keep from hiring male nurses in labor and delivery and gynecology, where female patients' private parts would be exposed due to the bodily privacy issues and potential sexual abuse. The same can be used for urology practices that need more male nurses for male patients. Think of another case in a non-medical setting where BFOQ can be applied. A clothing store will not hire male bra fitters. They are protected by BFOQ because many women are not comfortable with male bra fitters due to modesty concerns. A man would have a case if the store decided to not hire him to be a cashier or manager because bodily privacy is not involved. Here are a few examples of male nurses or nursing assistants abusing women. A burn ward patient at an Illinois hospital objected directly to the male nurse who groped her while washing her, but he said that he was just doing his job. After this incident, the nurse briefly left the patient's room. He returned a short time later, climbed on top of her, and assaulted the patient by having a non-consensual sex with her. She was in a vulnerable position because she had a difficult recovery. A 34-year-old lady recovering from ovarian cyst removal surgery at a California hospital was sexually abused by a male nursing assistant. The jury awarded this lady $65 million in punitive damages. This is exactly why it is wise not to permit male nurses or assistants to work in women's health services. 12 women accused a male nurse, Adam Lim, of groping them as patients in at least 4 Salt Lake City area hospitals. But for a decade, Utah hospitals kept hiring him anyway. Luis Gomez, a CNA in Waynesville, North Carolina, a small town, raped numerous women at a nursing home in town. Complaints were ignored. In fact, one woman complained to the director of nursing. She reacted with disbelief. The director of nursing told the resident, quote, to go live under a bridge because nothing like that happened in her facility, the woman recalled. More women came forward. But the director of nursing still would not do anything and did not believe them. She was too eventually fired later. After a week-long trial, Gomez was found guilty of raping 2 Bryan Center residents and convicted on 6 counts that included forcible rape with a physical helpless victim. Maggie from Salt Lake City area had a hysterectomy at one of the hospitals where nurse Adam Lim worked at previously. This same hospital employs male midwives, something unheard of at most hospitals in the United States, and male nurses in gynecology. She chose a women's cancer center in Salt Lake City that had an all-female medical staff, including a female gynecologic oncologist, to do her hysterectomy. She shared with them that she wanted an all-female team for her hysterectomy, and she was deceived, believing her wishes would be honored. About 10 minutes before Maggie's surgery, she was mortified to learn that the anesthesiologist and circulating nurse were males. They both knew Maggie's concerns. Maggie shared this with the medical patient Modesty. To be clear, both the anesthesiologist and nurse knew I was very concerned. My Modesty concerns were no secret to anyone. As the 2 men entered the waiting room area silently, I was talking to my husband with my head turned in the opposite direction of where they entered and of my IV. They were standing there for about 15 seconds when I suddenly realized they were handling my IV. I said, "Please don't give me anything. I want to be aware so I know who is in the OR." The anesthesiologist said, "Don't worry, we're taking care of you." That's the last thing I remember. I have no other memory for over 6 hours. The day after the surgery, I saw the person who I thought was the assistant for my surgery. She told me and my husband that the surgery went well and gave me post-op instructions before I was released. She made no indication that she was not in the OR with me. As a matter of fact, all her comments intentionally led us to believe she had assisted the doctor.
Finally, a week after surgery, when I was still having trouble remembering things, I called the anesthesiologist to see why I couldn't even remember being taken into surgery, being prepped, or when I was given anesthesia. He told me, "Oh, that's probably the Versed I gave you in the waiting area." I was stunned. I reminded him that I had explicitly asked to not be drugged before entering the operating room. He told me that they knew I'd object to the males in the room, so they gave me the Versed to calm you down. I was mortified. I then requested my records from the hospital and learned that the team was almost entirely male, including the assistant.
I called the surgeon whom I had trusted to try to make sense of what happened. Basically, she told me that all the men are professionals and that I shouldn't be worried about what they did or saw. They do it all the time. Let's be clear about what they did and saw. They stripped me completely naked, spread my legs apart, put my legs into stirrups, scrubbed my body, cleaned my vagina, let me lay naked for at least another 10 minutes while I dried, and inserted their fingers and other objects into my vagina, all without my explicit consent and after being rendered unconscious deceitfully and against my will. When I asked her why I wasn't informed that she replaced her normal assistant with a male, she in essence let me know it's not to her responsibility to tell me who will be assisting or who is in the surgical area. When I contacted the hospital to find out when 90% of all nurses are female, why would they put males to assist for gynecological surgery? I was informed that gender does not matter. All nurses are professionals. I pointed out to both the doctor and the hospital that not one OBGYN in the area has males assist when the patient is awake, and that the women should be treated with the same level of respect when unconscious as they are when conscious. Both said that surgery is different. That's why people are sedated. Hospitals, surgeons don't want patients to know what's happening during surgery. It's not necessary. Most patients, like you, would just object, so sedation helps everyone. What happened to Maggie is sadly common. It is true that many doctors and hospitals have this mentality that modesty does not matter when a patient is under anesthesia. Notice how this female gynecologic oncologist and surgeon defended the male medical personnel by arguing that they were professionals and that they saw women's private parts all the time. This does not change the fact that many women are uncomfortable with men seeing their private parts. The attitude of the gynecologic oncologist is callous. She also supports the gender-neutral agenda of the medical industry, meaning that the gender of medical professionals does not matter. It's sad that she had an all-female office staff, but does not think it matters when you are sedated or under anesthesia. This gynecologic oncologist received many great reviews from patients who are likely unaware about what really happened to them during surgery. This is exactly why every patient should have a personal advocate not employed by the hospital to be present for their surgery. Maggie's case is very sad because many women in her situation choose an all-female practice with the purpose of avoiding male medical personnel. It is even sadder that this gynecologic oncologist treats so many women with gynecologic cancers. Cancer is already a very hard time, and cancer patients should be treated with dignity. Many cancer patients care about modesty, but they are so focused on getting rid of their cancer, and they feel they cannot really question medical professionals. We appreciate Maggie helping us with this article.
Concerns about modesty during hysterectomy? patientmodesty.org/hysterectomymodesty.aspx. Sedation, Versed, and your procedure. patientmodesty.org/Versed.aspx.
She wanted to help to educate other patients so they would not have to endure what she went through. Fortunately, one husband saw the hysterectomy article and was able to take steps to ensure that his wife's wishes for Modesty, an all-female team for hysterectomy in Minnesota, were honored. He was even able to be present for the surgery. Maggie reveals the truth about all what happens to women as they are being prepped for hysterectomy and during hysterectomy in the article. Concerns about modesty during hysterectomy. Some women may assume that they won't be that exposed for an abdominal hysterectomy, but the truth is abdominal hysterectomy patients are also put in stirrups like they are having a pelvic exam. In many cases, especially at a teaching hospital, some medical students will take turns doing a pelvic exam on you under anesthesia, mainly for learning purposes. Some medical students even do pelvic exams on gynecological surgery patients without their consent. Your gown will then be removed or pulled up to allow access to your abdomen and genitals. Your vagina and rectum will be prepped and cleaned inside and out. And if you are having either an abdominal or laparoscopic hysterectomy, your abdomen will also be cleaned. You will be draped. There will be openings in the drape for your vagina and abdomen. A urinary catheter will be inserted, and depending on the procedure, other objects like a speculum or uterine manipulator will be inserted through your vagina. Hospital scrub nurse, circulating nurse often does the vaginal prep on you. Male circulating nurses are assigned to some gynecological surgeries at some hospitals, like the hospital in Utah that Maggie had her hysterectomy at. In some hospitals, there are windows everywhere so that people can watch procedures. Some hospitals screen windows for gynecological procedures and others do not. Also, many people are unaware of surgical technicians until they have surgery. Many of these techs have minimal training, which could consist of as little as a 6-month course. In most states, surgical techs are not licensed or certified, but work under guise of the surgeon and/or facility where they are employed. Being registered with the facility is many times the only employment requirement, and registration oftentimes consists of only name, address, and phone number. One lobectomy patient from Florida was very upset to learn that she was stripped naked for surgery and that she had male surgical technicians present in that surgery. When this patient challenged the hospital, they argued that the surgical technicians were professionals and that it would be discrimination against the techs not to allow them to work on her as the naked patient, and that the male surgical technicians are more mechanically inclined, therefore especially needed in surgeries and operating rooms where machines could malfunction. A professor who teaches a surgical technician curriculum at Florida College spearheaded a campaign to establish legislation which recognizes and certifies surgical techs that complete rigorous coursework. The group fought for more than 8 years, but was unsuccessful. Mandatory certification was not approved. Nationwide, even today, surgery techs are the least known, and many the least educated personnel in the operating room. Oftentimes are minimally paid, yet perform intimate procedures such as shaving, prepping, catheterization, and suturing. Departments such as cardiac heart unit, ICU, general surgery, orthopedic surgery, and psychiatric that serve both female and male patients should hire nurses of both genders. Accommodating patients with the same gender nurses should be a hospital's priority because of modesty preferences. For intimate procedures, many nurses departments assign nurses to patients without considering gender and without the patient's or family's consent. Many male patients feel very strongly against having a female nurse for intimate male procedures. And for that reason, hospitals should work hard to accommodate men's wishes for modesty by having enough male nurses available. Many men are less likely than women to speak up about how they feel about their modesty, because men usually do not like to communicate their feelings about personal matters. Oftentimes, men actually avoid medical treatments due to concerns about their modesty. Because of their limited numbers, male nurses and technicians are often simply not available to do intimate male procedures, such as urinary catheterizations and scrotal ultrasounds. Also, getting an all-male surgical team for intimate male surgeries, such as a vasectomy, prostatectomy, hernia repair, and etc., is difficult to schedule at many hospitals. Scheduling an all-female surgery team for a female patient's procedure is more accessible because most hospitals employ a limited number of male nurses working in gynecology. Many men actually prefer that their wives give them a bath in the hospital, and medical professionals should respect their wishes and allow wives to bathe their husbands in privacy.
In the 1970s and before that era, men had intimate procedures such as urinary catheterizations done by male doctors or orderlies in the hospital. The gender neutrality of the medical industry changed this, and it is pretty common for female nurses and CNAs to do intimate procedures on male patients today.
There are some very callous female nurses who mock male patients who are modest. Also, there have been numerous female nurses who have made derogatory comments about genitals of male patients, especially those under anesthesia. Also, some female nurses have put up jokes on their Facebook pages that they have seen more private parts than prostitutes. Here's one example of a female nurse who violated male patients.
Kristen Johnson, a former nurse in upstate New York, in 2016 turned over her nursing license after being convicted of photographing several naked and anesthetized male patients' genitals and texting pictures.
Some nursing homes have become gender neutral in their nursing assignments. Male CNAs even help with bathing women, taking them to the bathroom. Also, some home health agencies send male CNAs to bathe elderly women. Medical Patient Modesty received this email from an anesthesiologist in South Florida in 2016, upset about his mom being bathed by a male aide at a nursing home occasionally. I am a physician in South Florida. I have my mother in a nursing home and have recently discovered that she is being bathed by a male aide on occasion. She is uncomfortable with this. I know that in a hospital setting, this would be unheard of and extremely inappropriate. I have spoken to the director who told me that he will reassign to make sure that my mother will have a female aide, but stated that he does not have any policy language about this issue and will continue the practice with other residents. I want your opinion. Is it considered standard of care to allow this gender-neutral approach to intimate activities like cleaning genitalia? Sadly, this doctor was unaware about how nursing homes and hospitals had become gender-neutral in the past 10 years. This would have been unheard of 20 to 30 years ago. Many people are also unaware until their loved one has been hospitalized or put in a nursing home. Nursing homes and hospitals may use the excuse that a male nurse has to assist in bathing certain women because of heavy lifting, ensuring the patient is not dropped. This is not true. Due to the potential of sexual abuse, this is very risky. A female nurse or assistant should always bathe a woman. A male nurse or assistant could help lift a clothed woman into the bathtub if necessary. Leave while a female nurse or assistant bathes her. Be called back to get the patient out of the bathtub after the woman has been redressed. It is also safer to use appropriate equipment when necessary, including Hoyer lifters, easy pivot, and similar devices designed for lifting patients as to reduce the risk of employee injury. Sponge bed baths for very frail female patients require no lifting or male assistance whatsoever. Nursing homes should never assign male nurses or assistants to female patients for intimate care tasks such as bathing, changing diapers, dressing, or cleaning women's private parts after bowel movements, etc., due to potential sexual abuse. Nursing homes certainly should continue to hire male nurses and assistants to work with male patients for intimate care. When hospitalized, all female patients should express that they do not want male nurses helping with bathing or intimate procedures. Family members are encouraged to speak to nursing home administrator about not allowing male assistants with their female relatives. Everyone is encouraged to check out personal care garments that help to protect your modesty during assisted bathing and toileting through Dignity Resource Council. Their website is www.dignityrc.org. We are going to show a short video about those personal care garments by Dignity Resource Council now.
Hi, I'm Robin Leonard, Executive Director of Dignity Resource Council, a nonprofit organization that provides awareness of the need for dignity preservation during assisted bathing and other personal care. As a former caregiver, I know firsthand the challenge you can face when assisting a loved one, especially with bathing. When I first cared for my mom, I worried about how I could protect her dignity, dreading the day she would be helped with bathing and other personal hygiene needs. There was nothing on the market that covered the body, especially during a shower. No wonder why so many people refused help with bathing. Did you know that being naked in the presence of a caregiver can be so humiliating? But through my frustration, I was inspired to design a first-of-its-kind bathing accessory, especially for personal care. Now, it had to be water-friendly and cover modestly without getting in the way of personal hygiene. My mom was the first one to use the prototype, and it's now called the Honor Guard. It changed both of our lives. The anxiety she once felt was replaced with a sense of dignity and privacy. Let me show you how it works. I'm so excited to show this to you. This is called a triple flap piece, and it wraps around your torso. It's so simple to use. Now for a man, this is all you need. Well, for changing clothes, needing help with the commode. But notice how it has 3 flaps, and the panels, they just stay on with gravity, and a little piece of Velcro. Let me show you. You see how it attaches in the back? And it overlaps. The reason why is so when you sit down it parts. It doesn't get in the way when you're in a shower chair. So as you can see, you can easily unzip, pull down, pull up, anything underneath. So you don't get in the way of hygiene. It works perfectly in the shower. Now, as you're washing, say for example, for a woman, we have this piece, which is called the chest shield. And it's the same type of fabric. We have the mesh. In fact, it's like what surfers wear. It's that, it's sort of like the water-resistant material where it beads up. And the mesh makes it nice because you don't get that wet t-shirt look, if you know what I mean. So watch how easy. This too is held on with gravity and Velcro. Now we do add some Velcro here because in case, you know, maybe the posture might be a little bad, it won't open and expose. But underneath, you can wash, whether it be with the help of a caregiver or yourself. I like it. In fact, I took this to summer camp one year when I had a lot of girls, and they loved it. They can get dressed and undressed into their swimsuits or their PJs and didn't have to worry when it came to showers. I'm covered. I loved it. But anyway, as you're washing, you can see the water runs off, and it's time to get out of the shower. So what do? You dry off. But I want to remind you, always cover, then remove. So before we remove this piece, we want to cover it. And we have a matching piece in terry cloth. So simple. Remember I said cover, then remove? So we're going to cover, then remove. And now, the terry cloth is against the skin. It absorbs the moisture. And it's so simple. The bra can come on with ease. Now, once you're dressed, then you can remove this. And the same with the lower piece. It's so simple. And you can see we don't need panels or flaps here, just one solid piece. So just wrap around and then pull underneath. Off it comes. You shake it off. This comes off, but not until you want to get dressed under it. So you cover, then remove. And it's so simple. Now for bed baths, the normal way to do a bed bath, so I've heard it was taught, was to expose the part you want to wash, then wash. Not so with this. In fact, you cover, then you can wash. And the terry cloth works against the skin, just like when you dry. So you don't have to be embarrassed. This will take you through all activities of daily living, whether it be commode use, taking a shower, bed baths, or taking a bath. We got you covered.
Gender neutrality at all levels of medical training and practice is the root of all the modesty violations and sexual abuse by medical professionals. We need to challenge hospitals that are gender neutral and not give in to their arguments that gender does not matter because medical personnel are professionals and they've seen it all. The medical industry tries to indoctrinate us to accept that gender does not matter and that we should just focus on the skills of a medical personnel rather than gender.
Many people are unaware of how modern gynecology was started and how men, male doctors and male midwives, took over providing gynecological procedures in childbirth when medical school was invented. Before modern medicine, men were not allowed to be present at births or other procedures that dealt with the intimate parts of women. Many midwives, when medical schools were established, bitterly opposed the involvement of men in childbirth. Some male practitioners also opposed the involvement of medical men like themselves in midwifery, and even went as far as to say that male midwives only undertook midwifery solely for perverse erotic satisfaction. Midwives played a role in the development of obstetrics, for through most of the 20th century, midwives have been thrust to the sidelines. Fortunately, midwifery is making a comeback, and thousands of women enjoy the care of midwives and OBs. Either way, midwives are the ones who have assisted women during labor for thousands upon thousands of years. Without them, and their copious amounts of knowledge, the first rung of obstetrics would have never been climbed. In fact, until the 20th century, the science of obstetrics was still referred to as midwifery in medical schools, and obstetrics is the Latin word for midwife. Once the field of medicine and the arena of pregnancy and childbirth were usurped by modern medicine, all doctors, including obstetricians, were men. The first female to graduate from medical school was Elizabeth Blackwell back in 1849, although it took more than a century and a half for female doctors to be considered normal.
It became normal to see female doctors in practice. In fact, as of today, in 2019, there are many female doctors in different specialties, especially family medicine, pediatrics and obstetrics, and gynecology. A majority of OBGYN residents are females today. Some OBGYN residency programs in the United States, as of 2019, have only female residents and no male residents.
Here are some facts about first male gynecologists in America. Dr. James Marion Sims from South Carolina is said to have invented modern gynecology in America. He is considered the father of modern gynecology. Dr. Sims is known for inventing gynecological techniques we still use today. Most notably, he invented a surgical technique to repair vesicovaginal fistula. Beginning in 1845, Dr. Sims developed a surgical technique to cure this taboo medical condition through experimentation on human subjects. What makes Dr. Sims' experimental technique so horrific is that he used enslaved black women as human subjects for his research, and because these women were considered to be property, they could not consent to these appalling procedures. In fact, their owners were allowed to consent for them, owners with a strong financial interest in the success of these surgeries. Even worse, Dr. Sims performed these surgical procedures on black women without anesthesia because of his belief that black women were not capable of feeling pain. However, the very real pain of Betsy, Anarcha, and Lucy are detailed in Dr. Sims' many journals. Not only did Dr. Sims violate these women without their consent, he also invited people to watch as he performed these experimental surgeries, further stealing the dignity of the women who were forced to partake in his research. Dr. Sims performed 35 surgeries on one single human subject, Anarcha, before completing a single successful surgery. In October 1889, Dr. Howard Atwood Kelly was appointed the first professor of gynecology and obstetrics, and is universally regarded as establishing gynecology as a surgical specialty. By the late 19th century, the foundation of modern-day obstetrics and midwifery began to develop. Delivery of babies by doctors became popular and readily accepted, but midwives continued to play a role in childbirth. The American College of Obstetricians and Gynecologists, founded in 1951, is a professional association of physicians specializing in obstetrics and gynecology in the United States. It is an organization with a membership of approximately 58,000 obstetrician gynecologists and women's healthcare professionals. A majority of OBGYNs in 1951 were males. Look at this important section about historical progression of pelvic exams in the article, Male Physicians Treating Female Patients, Issues, Controversies, and Gynecology on NCBI's website.
The oldest medical text known to man is the Kahan Gynecological Papyrus, written by the Egyptians around 1800 BCE. The papyrus provides a glance into early gynecological medicine and unveils the traditions of reproduction, conception, and delivery in ancient Egypt. Due to compliance with religious doctrine, men were not allowed to be present at births or at other rituals that dealt with the intimate parts of a woman. Instead, it was the role of the midwife to take care of women and to assist them with their gynecological needs. Interestingly enough, the Qumran papyrus provides some of the earliest evidence of midwifery in history. Similarly, in the Middle Ages, it was often the norm for a woman's sexual organs to be examined by midwives, nurses, and other females who previously had similar problems to the patients. By the early 1800s, with the advent of modern medical degrees and physical examinations, the pelvic exam began to be performed by male physicians, as women were not allowed to enroll in medical school. However, this examination was a variation of the modern version, as it consisted of a compromise in which the physician kneeled before the woman but did not directly inspect her genitals, only palpated them. Here's a drawing of a male doctor kneeling before a woman and inspecting her genitals without looking at them in 1822. The historic taboo associated with the examination of female genitalia has long inhibited the science of gynecology. This 1822 drawing by Jacques-Pierre Magrier shows a compromise procedure in which the physician is kneeling before the woman but cannot see her genitalia. Modern gynecology no longer uses such a position. The drawing is when they first introduced men to do gynecological procedures on women. The above picture is how a pelvic exam is performed today. Speculum, in 3 above, is used for the pap smear. In addition, it was during this period that the use of a chaperone became a part of the clinical examination. The chaperone's role was to emotionally support and reassure the patient during a procedure that she found embarrassing or uncomfortable. The chaperone also acted as a witness in cases of malfeasance by the physician. Today, in many parts of the world where religious and cultural precepts often discourage female encounters with male physicians, chaperones still attend gynecological examinations.
The truth is, chaperones are pretty useless. They're just there to protect the doctor. Modern medicine has worked to indoctrinate us that the gender of a gynecologist does not matter. Male gynecologists often charm women into accepting them due to their impressive surgical skills and training, compassion, and gentleness. Many male gynecologists who have sexually abused women were very professional, compassionate, and gentle, and skilled. Our culture sees doctors as experts on the body, and the medical industry has worked to indoctrinate even the most modest women, those with very strict standards, such as not wearing a 2-piece bathing suit and no sex until marriage, to accept that male gynecologists are okay over the past few centuries since modern medicine started. Because most gynecologists were males until recently, women of the past few generations conditioned their daughters to go to male gynecologists because that's what their mothers did. This is a huge cultural blind spot. This also confirms that doctors have so much power in our society. Think about this scenario. A teenage daughter has a tampon stuck, and she needs help to retrieve it. Her mom tried to retrieve it but could not. The girl's father is better than her mother at retrieving things. Would it be appropriate for the girl's father to retrieve the tampon simply because he's more experienced than his wife? If the girl's mom cannot retrieve the tampon, they should look for another woman to retrieve it. The same should be true of a doctor. You should look for a female doctor until you find the one that is skilled for your case, even if it means traveling farther. The truth is, most people in our society would accuse the father in this scenario of incest if he helped to remove a tampon from his teenage daughter, even if he had great intentions. But they would not look down on a male doctor removing the teenage girl's tampon simply because he is a doctor. This is ridiculous because a male doctor is still a man.
If indeed the pelvic exam is a simple medical procedure, then a male doctor should not hesitate to perform an intimate exam on his own mother, or his own daughter, or his sister, or any other female relative. Of course, the mere thought of such an intimate exam on a close relative is alarming and disgusting to consider. Why? Because it raises the image of incest, sex among relatives, one of the most forbidding actions in human behavior. From this simple illustration, we know positively that a pelvic exam is loaded with sexuality. It is not a mere medical procedure. In denying the sexuality of the pelvic exam for a century, the medical profession has been committing a fraud, a deliberate misrepresentation, on female patients. Sons do not look up their mother's skirt, and fathers do not look up their daughter's skirt. Brothers do not look up their sister's skirt. While it is great that modern gynecology has brought improvements such as C-sections that have cut down on maternal deaths, surgeries for gynecologic cancers, etc., only women should have been allowed to be gynecologists in the beginning. Medical school made a huge mistake by allowing only men to become gynecologists. Thankfully, there has been a big increase in female gynecologists in the 21st century. But there are still some rural areas and cities that do not have enough female gynecologists and gynecologic oncologists. Most small towns in the United States do not even have gynecologic oncologists. Women often have to travel to the closest biggest city if they need a gynecologic oncologist. Some of those cities do not even have one female gynecologic oncologist. For example, as of October 2018, there are only 2 female gynecologic oncologists in the entire state of South Carolina in the city of Charleston. Many women dread having gynecological procedures. They see no sexual connotations to those procedures, so they assume that it is impossible for a male doctor to have any lustful thoughts, especially because they do gynecological procedures all the time. Also, many women are so focused on making sure that they do not have cancer or getting rid of cancer, and this is why they submit to gynecological procedures without questioning them. They trust their male gynecologist's expertise. Also, many women who used male gynecologists to deliver their babies over the past 2 centuries were focused on doing whatever it took to make sure their baby was healthy. Some women have fallen to the misconception that male doctors are better at surgeries because they came from a generation that believed that men could do certain jobs such as flying airplanes, surgeries, police work, etc., better than women. The reality is, there are so many wonderful and talented female surgeons who have saved many patients' lives or helped to fix their health issues. In fact, Time magazine had an article on October 10, 2017 titled, "Researchers Find Women Make Better Surgeons Than Men." In this study, patients' deaths and complications were lower with female surgeons. But the truth is, men, no matter how good their intentions are, often have lustful thoughts when they see a woman's private parts. Male doctors are no different from other men. Male doctors often have normal sex lives. Many of them are married with children. No amount of training changes the fact they are men. Interestingly, many women who go to a male gynecologist would be very upset if their husbands were gynecologists. Many of them would never consider marrying a male gynecologist because they cringe at the thought of their husbands seeing and handling private parts of other women for a living. Women and men differ in their sexual responses. Rare is the man who can approach the idea of being asked to touch a naked female in her intimate parts in any context without a hint of sexuality entering his mind. Females are usually only eroticized by proper mood and situation, but the male sexual response is visual, tactile, and immediate. This is exactly why women rarely think about how a gynecological procedure could be sexual for a male doctor. Sadly, some female gynecologists are very insensitive to women's modesty today because they see nothing wrong with referring a woman to another male doctor, such as a gynecologic oncologist or fertility specialist. Many female gynecologists rotate with male gynecologists who could deliver their patients babies. Also, some female gynecologists use male medical personnel, such as medical students, residents, nurses, etc., to assist them with gynecological procedures. Some female gynecologists have been desensitized in medical school that gender does not matter and that modesty is not important. Some women are not really aware with what a gynecologic oncologist is, unless they or their family members have been referred to a gynecologic oncologist because it is suspected that they could have a gynecological cancer. Women are often taken off guard when they're referred to a gynecologic oncologist because they are so worried about having cancer, and they may put modesty aside for at least a while until they really think about it. One female doctor even tried to persuade a woman who made it clear that she would not accept a male doctor for female health issues to see a male gynecologic oncologist in case she needed surgery because it was suspected that she might have endometrial cancer. This female doctor said everyone raves about him and argued that he was a great doctor, but the female patient did some research and found out that some patients had actually complained about him. One female gynecologist in an all-female practice that does not rotate with male doctors for delivering babies will refer women to a male gynecologic oncologist, who she argues is very good. Male gynecologic oncologists often have a good reputation in the medical community because many of them hold high positions, such as professor at a medical school, director of robotic surgery at the hospital, the top surgeon who has done thousands of surgeries, etc. The reality is, many male gynecologic oncologists are full of themselves, and they often strive to do as many surgeries, especially full hysterectomies, as possible, even on women who may not have cancer. Some of them may act very compassionate and professional to patients when they are awake, but they are different when patients are on anesthesia and in their personal lives. Remember, we mentioned earlier that Time magazine had a study that showed women were better surgeons. Female doctors are most likely to be open to watchful waiting and saving as many of a woman's female organs as possible, especially if it is not for sure that she has cancer. Look at this one case of a woman who had a large suspicious mass on her ovary. A female gynecologic oncologist only removed one ovary that had the mass to biopsy it rather than doing a full hysterectomy. Then, after it was found out this patient indeed had ovarian cancer, the female gynecologic oncologist moved forward with a second surgery to do a full hysterectomy on her because it was the right course of action for ovarian cancer. It's very encouraging that this female gynecologic oncologist was planning on saving this lady's uterus and ovary in case the ovarian mass was benign. Many major cities in the United States have more female regular gynecologists than male gynecologists, but more male gynecologic oncologists than female gynecologic oncologists as of 2019. This poses a serious problem for modest women who need an appointment with a gynecologic oncologist as soon as possible. It's often easier and quicker to schedule an appointment with a male gynecologic oncologist if there are 2 or 3 male gynecologic oncologists and only one female gynecologic oncologist at an oncology clinic. Sometimes a female gynecologic oncologist could have a waiting list. We need more female gynecologic oncologists, and hopefully they will outnumber male gynecologic oncologists in the near future. If you have ever suspected cancer, and if your gynecologist refers you to a male gynecologic oncologist, firmly tell her no, and that you will not accept a male gynecologic oncologist. She may make some arguments about you using a male gynecologic oncologist because, 1, he has a lot of experience and has a lot of great reviews from patients she referred to him. 2, he is the best surgeon in the area and he has done thousands of surgeries with great results. Those arguments do not change the fact that he is male. Be willing to travel farther to see a female gynecologic oncologist who can take you as a patient, perhaps spending the night away from home. There are many wonderful and talented female gynecologic oncologists out there. You can go to Medical Patient Modesty's website to check out what steps you will need to take to ensure no male medical personnel are present if you require surgery.
Dr. John Smith, a former male gynecologist who courageously spoke up that after 24 years of medical education and clinical gynecological experience, that men should not be gynecologists, shared this in his book, Women and Doctors. No other professional in America enjoys the degree of authority that doctors have managed to secure. Almost unquestioned in their judgments, they have been given the authority to exercise power in areas that extend beyond their medical area of competence. Physicians can also decide if you should be allowed to do certain kinds of work or if you can play a sport in school, and can exercise unquestioned power in myriad other aspects of your life. This is very true. Many doctors push patients into making decisions that they would not normally make in another setting.
We encourage everyone to read Dr. John Smith's book, Women and Doctors, that was published by Dell Publishing in 1992, that exposes the gynecology industry and how women are often mistreated by male gynecologists. You can find the book on Amazon. Make sure you especially read the chapters 3, The Behavior of Doctors in General, and 4, The Miscasting of Males as Gynecologists in Women and Doctors by Dr. John Smith. The book is outdated on some medical procedures such as pap smears and pelvic exams because guidelines have changed since then, but those 2 chapters are still relevant today. His chapter on unnecessary surgeries is still relevant because a lot of unnecessary hysterectomies are done today.
Dr. Smith shared that he had to do a lot of soul searching as a male gynecologist. Male gynecologists, like all men, go through the kind of attitude setting that occurs in the proverbial locker rooms while they are growing into manhood. Dr. Smith, whose practice was in Colorado Springs, says that it is common and acceptable among practicing gynecologists to speak about their patients' bodies, sexual behavior, or medical problems indiscriminately in terms that are demeaning and reflect a lack of kindness and respect. Becoming more explicit, he charges them with eroticizing the medical scene. It is a rare male who is able to see women day in and day out, examine their bodies, hear details of their sex lives, and not only never have a lascivious thought or abuse that access, but always remain clinical. He confesses that I have had a colleague invite me to do an exam on one of his patients under the false guise of a consultation because she has a body you won't believe. I have seen more than one gynecologist walk into an operating room where another doctor's patient was already asleep for surgery, lift up the sheet, admire the patient's breasts, and continue his conversation without pause.
Dr. Smith concluded dramatically, after 24 years of medical education and clinical gynecological experience, it is my opinion that males should not be gynecologists. The role properly belongs to women. This is amazing that Dr. Smith exposed the gynecology industry and came to this conclusion that men should not be gynecologists. Most male gynecologists are very defensive when you question them.
Dr. John Smith also made some other important points in the book that we wanted to mention in this video.
Number 1. At this point, many of you are saying, "Not my doctor. My doctor is honest, competent, and has only my welfare at heart." Please understand that a pleasant demeanor and impressive diplomas and certificates do not mean your doctor is incapable of the behavior I will describe in this book. This is true. Many of the male gynecologists who have abused women fool their patients by their professionalism, knowledge, and compassion. Number 2. Too often, women rely on gynecologists' reputation, and if it appears to be good, they assume the gynecologist, too, is good. It is rare to hear information about how bad a doctor is, except from former patients, and they often do not have a large audience. It's much more common today to hear, in a hospital's advertisements, for instance, that their staff physicians are all terrific, well-trained, caring, and attentive. This is very true. In fact, many doctors are able to have their negative reviews from their patients on their websites removed. One hospital in Ohio continued to show an ad about how wonderful one colorectal surgeon was, even after he had anally raped a patient. Number 3. What do you call it if a doctor subjects your daughter to a breast and pelvic exam when there is no medical indication for it and your daughter did not ask for it? Is it any less a sexual assault than her being fondled and disrobed by a date who thinks he has the right? This is very true. In fact, a male doctor who claimed to be a Christian got away with doing unnecessary breast exams on high school students for sports physicals in a small town in North Carolina. If he had been a teacher instead, he would have been fired from his job and possibly sentenced to time in prison for sexual abuse. Look how long it took for Dr. Larry Nassar, the former doctor for U.S. women's gymnastics team, to get in trouble for sexually abusing over 150 girls and women. Number 4. In recent years, we have recognized the seduction of a woman by her psychiatrist is in fact a criminal act. Similar abuse occurs in the gynecological setting, but it is called something else. Perhaps because women have not felt sufficiently empowered to threaten gynecologist positions, these doctors have not been subjected to the same level of scrutiny as other professionals. This is very true. So many gynecologists can get away with abusing women. Many women are too embarrassed or scared to report their gynecologists. Many women want to report their doctors anonymously, but this is not possible, so they just stay silent. Also, most medical boards won't do much about gynecologists who have abused women. In fact, medical boards in some states are often secretive about complaints they may have received about sexual abuse by doctors. Number 5. Hysterectomies are deliberately sold to women by doctors who use the operation as their major source of income. They are done by well-meaning but misguided physicians who believe women are better off without their uterus. Mostly they are done by male physicians who were trained in a milieu that did nothing to alter their ingrained male prejudices about women, and that reinforced the attitude that it is all right to decide for a woman what she needs, instead of giving her knowledge and power to make the decision for herself. This is true. The United States has the highest rate of hysterectomy in the world. Approximately 600,000 hysterectomies performed each year in the United States. It is estimated that 85% to 90% of all hysterectomies are unnecessary, so it's important for the women to get a second opinion and do some research on alternative options before they proceed with a hysterectomy. Gynecologists, hospitals, and pharmaceutical companies make more than $17 billion a year from hysterectomies. Also, male gynecologists are more likely to do unnecessary hysterectomies on women. In fact, one OB/GYN practice in North Carolina that has 3 male gynecologists has a very high hysterectomy rate. They've done so many unnecessary hysterectomies on women, mostly for benign conditions, including one lady in her 70s for a prolapsed bladder that was unnecessary. Some doctors use scare tactics to push women into having a hysterectomy, such as telling her that she could develop cancer later due to endometriosis or another benign condition that she has. Also, many doctors tell postmenopausal women and women who do not plan on having any more children that a hysterectomy is a good option for them without telling them the long-term risks, such as heart disease, high blood pressure, etc., they could develop as a result of the hysterectomy later in life. Hysterectomy is only medically necessary for saving a woman's life. Hysterectomy should only be done in the case of several life-threatening conditions. Invasive cancer of the uterus, cervix, vagina, fallopian tubes, and or ovaries. Unmanageable infections such as gangrene on the uterus that could cause sepsis. Unmanageable bleeding. Serious complications during childbirth, such as rupture of the uterus. We encourage all women to take time to read the following articles on Medical Patient Modesty's website. They can be found under Female Patient Modesty. Number 1. Are Pap smears necessary for virgins? Number 2. Truth about Pap smears. Number 3. Truth about pelvic exams. ACOG has misguided guidelines about Pap smears and pelvic exams because they have had the same guidelines for all women and age groups. The truth is, pelvic exams are basically useless for healthy women who are not pregnant with no symptoms. ACOG does not address that some women may be at a higher risk for cervical cancer, while some women, such as complete virgins who have never engaged in any kind of sexual activity, basically have zero risk for cervical cancer. 99% of cervical cancer cases are caused by HPV, a sexually transmitted disease. Pap smear is a screening test for cervical cancer only. Ovarian cancer is extremely rare, and the most reliable way to diagnose ovarian cancer is through an ultrasound or blood test, not a pelvic exam. Now we will talk about why women should avoid male doctors for intimate female health issues and tips women can take to prevent sexual abuse in medical settings. It is prudent for women to avoid male doctors for intimate female health issues. It's always a risk to allow a male doctor to do intimate procedures such as colonoscopies, pelvic exams, Pap smears, rectal exams, and breast exams on you. Countless male doctors and other male medical professionals have sexually abused female patients. A woman is at far greater risk of becoming a victim of sexual abuse at the hands of a male nurse, a male doctor, or especially a male gynecologist than she is from a man in the general population. Sexual abuse and voyeurism by male doctors would most likely not have happened if male doctors had been discouraged or even prohibited from performing intimate procedures when modern medicine began. We strongly encourage women who have a male gynecologist to switch to a female gynecologist. If your area does not have any female gynecologists, you should look into traveling to another town, even if it takes over an hour. We'll discuss a number of reasons why women should avoid male doctors for intimate procedures. Number 1. Countless male doctors have sexually abused female patients during intimate examinations. Remember that the nurse or assistant is present to protect the doctor and will often be on the doctor's side. There have been cases where female patients felt the male doctor went too far, but the nurse or assistant often testified that they saw nothing inappropriate and that the doctor was just being thorough. There was one case where everything happened so quickly that took the nurse off guard, and she was not able to report what happened until the female patient left. We will discuss this topic about how chaperones, or nurses, often do not protect patients later in this video. Do not forget that many well-respected male doctors have sexually abused women. Number 2. Male doctors are not morally above other men. Keep in mind that the male doctor could be enjoying the exam as though he was looking at pornography or a strip show, and that fantasizing about it later on after he leaves work. It is very normal for men to be aroused by seeing naked women, and a male doctor is no different. No amount of training can take the man out of a male doctor. No matter how professional the male doctor is, there is no chance that he could stay pure in his mind 100% of the time. Look at all the sexual misconduct cases involving OB/GYNs on www.sexualmisconductbydoctors.com. Number 3. Male doctors could take pictures of women's private parts secretly without anyone ever knowing. A number of male doctors have been involved in this voyeurism. Here are several examples of doctors participating in voyeurism. A well-respected male gynecologist, Dr. Nikita Levy, who was at Johns Hopkins Health System for over 25 years, secretly took pictures of his patients with the pen camera around his neck for a long time before he was arrested. Dr. Levy was only caught when a female colleague, a technician, noticed that the pen was in fact a camera and alerted the authorities. She had her suspicions confirmed when she secretly took the pen that was usually hanging on a lanyard from Levy's neck, plugged it into her home computer, and saw inappropriate images of his patients. Police later found an extraordinary amount of evidence at Levy's home, says a police officer quoted by ABC. This included over 1,200 videos and 140 images on his home computer. Think about how these women were further violated by having their nude images being viewed by teams of police personnel. Dr. Levy delivered many babies and helped a lot of women with female health problems. He was well respected in the medical community. His wife was a nurse at the hospital too. Many people say he was a super nice person and very caring. He was a family man with children who was involved in the community. Dr. Levy committed suicide after he was fired from the hospital. In a note left for his wife, he said, in part, "I am sorry, but I could not bear to see you suffer with this truth." Here's a picture of Dr. Levy holding a baby that he most likely helped to deliver from a New York Post article. If it had not been for that technician who courageously reported Dr. Levy, it is likely that he would have continued to practice without anyone finding out that he had been taking pictures of women's private parts. Medical professionals, such as nurses, are often afraid to expose a doctor's criminal activities for fear of being fired or facing discrimination in the workplace. Imagine how countless doctors are able to get away with voyeurism without anyone knowing. A hidden camera could be put in a doctor's stethoscope or something else, such as a necktie, which would likely be harder to detect than a pen camera. A doctor who wants to secretly take pictures of a woman's private parts will do anything possible to keep anyone from finding out. This is exactly what Dr. Levy did by having a pen camera. A 68-year-old gynecologist, Dr. Paul Beckton, who practiced over 30 years in Arkansas, videotaped women's private parts during pelvic exams with his cell phone. He was sentenced to 36 months on 4 charges of video voyeurism and forced to register as a sex offender. He was very well respected in the community. He was a member at a Baptist church and the director of a pro-life pregnancy center. He was also on the board of directors for several organizations, including Fellowship of Christian Athletes, Northwest Arkansas. He also volunteered at a charitable medical clinic. Many people in the community were shocked. Dr. George Tyndall, a full-time gynecologist at University of Southern California's Student Health Clinic for 27 years, who treated many female students and got away with abuse for a very long time. He treated thousands of females, still teenagers, seeing a gynecologist for the first time. The complaints started in 1990s, when co-workers complained he took pictures of students' genitals. The university let him practice for many years, even after the complaints. His chaperone saw some creepy things that concerned them. It took a while for the Medical Board of California to suspend Dr. Tyndall's medical license after he was finally fired from the University of Southern California. A 73-year-old male gynecologist, Oncologist in Albuquerque, had an affair with an employee in his practice who was also his patient. He is alleged of forcing her to have sex in order to keep her job. He also took photos of some patients' private parts during exams with his cell phone. His former partner, a female gynecologic oncologist, reported him to the medical board. Sadly, the medical board said that he could continue to see and treat patients despite his actions. But his former partner kicked him out of the practice and hired another female gynecologic oncologist, so this practice is now an all-female gynecologic oncology practice. When he left the practice, he converted the practice's cell phone to his own use, keeping the photographs. This male gynecologic oncologist was extremely well respected in the community, and this is probably why the medical board would not do too much, despite the fact that a physician having sexual relations with the patient violates the State Medical Practice Act and is deemed unethical by the American Medical Association. He was one of the best and top surgeons who had helped numerous women with gynecologic cancers. In fact, one lady who had stage 3 ovarian cancer he treated in 2002 was still alive in 2016, 14 years later. While it is true that some male doctors are very gentle and even more compassionate than some female doctors, keep in mind that many gentle and compassionate male doctors have sexually abused women. If you feel that your female gynecologist is too rough, just look for another female doctor or mid-level provider until you find one you are happy with. Be prepared to cancel your appointment if your female doctor is not available for some reason. Make sure that you look closely at the patient paperwork and make sure you do not sign something that guarantees payment of canceled appointments. Never accept a male doctor who may fill in for your female doctor. One lady who drove an hour for an appointment for a physical exam with a female doctor arrived at the doctor's office, discovered her female doctor was out sick. The receptionist informed her that she could see a male doctor, and she agreed for 2 reasons. First reason was because she thought that he would not really do anything intimate since she was not due for a pap smear. The second reason was because she had taken some time off work and did not want to take more time off work to reschedule the appointment to see the female doctor. It turned out that it was a big mistake because he pushed her into having breast exam, rectal exam, and pap smear. She shared her concerns with the nurse who was present, and she said that the male doctor always did thorough exams. Always make sure that you will have a female doctor or mid-level provider before you change into your gown, even if your appointment was made with a female provider. A male doctor could fill in for a female provider at the last minute without your knowledge.
Now we will talk about tips on preventing sexual abuse in medical settings. In our society, girls and women are always given tips on how to protect themselves from sexual abuse, but you rarely hear about how to prevent sexual abuse in medical settings. Sexual abuse in medical settings is more common than many people realize. Many doctors that have committed sexual misconduct have continued to practice. Most women would be too embarrassed or ashamed to report sexual abuse by a medical professional or brush it aside, feeling the medical care they received was worth the abuse. It is harder for a woman to report her doctor if he helped her through a difficult time such as a miscarriage, infertility, or cancer, and/or he gave her a special discount for procedures. Also, many women are afraid they won't be believed.
Larry Nassar, the former physician for the U.S. women's gymnastics team, sexually abused over 150 women and girls, most gymnasts. He did pelvic floor physical therapy that uses internal vaginal soft tissue manipulation or massage to relieve pelvic pain by accessing muscles that could not be reached any other way. This was unnecessary for his patients. He claimed that it helped with lower back pain and hip pains. This is primarily used for conditions like persistent pelvic pain, bowel and bladder problems like incontinence, and painful intercourse. Doctors usually do not do pelvic floor physical therapy, and they usually refer patients to physical therapists who specialize and are certified in it. And most of those therapists are women. Dr. Nassar duped patients, parents, and other physicians into believing that his treatments were medically appropriate, even after complaints were lodged. Even some girls had their mothers present when Dr. Nassar abused them. Dr. Nassar was sentenced to 40 to 175 years in prison. The truth is, Dr. Nassar had no medical reason to ever do intimate procedures on the girls since he was a sports medicine doctor.
Here are tips on how women can prevent sexual abuse in medical settings.
Number 1. Do not go to a male doctor for any intimate procedures on female organs. If you already have a male gynecologist, you should look at switching to a female gynecologist. There are so many good female gynecologists or nurse practitioners you can choose from. Having a nurse or an assistant present in the room with the doctor doesn't guarantee that nothing inappropriate would happen to you. Remember that the nurse or assistant is present to protect the doctor and will often be on the doctor's side. There have been cases where female patients felt the male doctor went too far, but the nurse or assistant felt he was simply doing thorough examinations. There was one case where everything happened so quickly that took the nurse off guard, and she was not able to report what happened until the female patient left. It would also be prudent to have a female doctor perform your colonoscopy if you must have the procedure. Some male gastroenterologists have taken advantage of women while under anesthesia for colonoscopy.
Here are some examples of doctors abusing women during colonoscopy and rectal procedures.
A top and well-respected colorectal surgeon, Dr. Ryan Williams in Ohio, anally raped some women who were sedated or under anesthesia. He helped many patients who had colon cancer, which makes this case even more difficult. One hospital in Cleveland where the first case happened, did not renew his contract, but did not tell the other hospital that hired him about the allegations. The second hospital later put him on administrative leave. But the medical board in Ohio has not suspended his medical license yet as of 2018. You can find more information on him by looking at proctology on sexualmisconductbydoctors.com. A Fort Myers doctor, Dr. Asif Kothuri, sexually assaulted some female patients during a colonoscopy. A nurse who watched him courageously reported him. The nurse could not keep him from sexually assaulting those patients. It is pretty common for doctors to abuse patients in the presence of a nurse. Those women would probably have never known that they were assaulted if it had not been for this nurse. Most nurses feel too intimidated to speak up when a doctor does something wrong. This is exactly why it is prudent for a woman to have her colonoscopy done by a female doctor. A Texas doctor, Dr. Anuruddha Chatale, abused many female patients during a colonoscopy. Some nurses complained, but the hospital ignored the complaints for about 2 years. One lady who he assaulted woke up with the doctor's semen on her face. Dr. Chatale agreed to permanently surrender his Texas medical license. Check out gastroenterology and proctology physicians on sexualmisconductbydoctors.com to see more doctors who have abused patients under Sexual Misconduct Cases by Physicians tab. Even with female gynecologists, you have to take some precautions. It is very rare for female gynecologists to commit sexual misconduct, but it is possible. Some female doctors are very coercive when it comes to doing things. You need to speak up about things you don't want to be done to you. For example, one female gynecologist ignored a lady's wishes in writing that she didn't want any medical students present for her C-section. Number 3. Do not allow yourself to be pressured into having a pelvic exam, pap smear, or breast exam at any doctor appointments. Some female patients have gone to the doctor for other health concerns and were pressured into having unnecessary examinations. For instance, if you go in for a sore throat and you think you may have strep throat, don't spend time listening to a lecture by a doctor about how important it is to have a pap smear and that you need one today. If something like that happens, tell the doctor you are not interested and you only want to talk about the reasons you came in. For example, your throat is sore. Number 4. Don't undress or put on a medical gown when it is unnecessary or you feel uncomfortable. Most procedures and tests, including blood tests, blood pressure tests, stethoscope heart exam, eye, ear, nose, and throat examinations, as well as throat cultures, can be done fully clothed. If your concern is an infection or suspicious spot on your skin, only uncover that part of your body and consider wearing a skirt, short sleeves, shorts, and socks or knee-highs to uncover the area of concern while remaining clothed. You should think in advance about what parts of your body the doctor should examine and dress accordingly. For instance, if you have a knee problem that you want the doctor to check out, you should put shorts instead of pants on so you will not have to take any of your clothes off. Number 5. Do not listen to recommendations from family members or friends about male gynecologists who may be good. Many people thought the male gynecologists who have sexually abused patients were wonderful doctors who would never do anything inappropriate. One virgin woman from Alabama went to a male gynecologist who was recommended by some women in her family who raved about how good his bedside manner was, said that he was horrible and coerced her into having an unnecessary pap smear. This lady thought she could trust this doctor because he delivered 3 of her cousins. This lady now suffers with PTSD. Number 6. If you are going to be put under anesthesia, you should insist that you have a personal advocate such as a family member or friend present for your procedure to protect you. Patients who are under general anesthesia are very vulnerable because they have no control over what happens. Many patients are unnecessarily stripped naked for surgeries. One female hand surgery patient had her gown and underwear removed after she was put under anesthesia. She found out because she woke up in the middle of the surgery. Number 7. Never assume that your male doctor of many years is not capable of abusing you because he has not abused you in the past. One lady was abused by her doctor after seeing him for many years. Number 8. If you have cancer or possible cancer and your gynecologist refers you to a gynecologic oncologist, make sure that the referral is to a female gynecologic oncologist. Do not listen to the argument that a male gynecologic oncologist is exempt since he is very skilled in helping with gynecologic cancers. A gynecologic oncologist often performs intimate procedures on women. Don't let the male gynecologic oncologist's impressive surgical skills and professionalism or the fact he may be the top doctor in your area fool you. Be willing to travel farther if necessary to find a good female gynecologic oncologist. Number 9. Make a firm decision that you will not let any male medical personnel, doctor, nurse, assistant, etc., touch any parts of your body that are covered by a two-piece bathing suit. Number 10. Insist that no male nurse give you a bath or do intimate procedures on you, such as urinary catheterizations. Many unnecessary urinary catheterizations are done. If you must be catheterized, ask that a female nurse insert your catheter. Number 11. Insist on a female technician for EKG, transvaginal ultrasound, if needed, etc. Number 12. If you must be hospitalized, it would be best if you could have someone not employed by the hospital present with you, at least most of the time, especially when you are asleep or drowsy.
The best way for women to prevent sexual abuse by doctors is to only go to a female doctor for intimate female health issues and to not let a male doctor or nurse see any private parts of her body that are covered by a two-piece bathing suit. Female patients are much more likely than male patients to be sexually abused in medical settings, but that does not mean that male patients are not at risk of being sexually abused too. Men are less likely than women to report sexual abuse. Go to www.sexualmisconductbydoctors.com to check out tips for male patients under the Important Tips tab about how male patients can prevent sexual abuse in medical settings.
One female ear, nose, and throat doctor, Dr. Twana Sparks, abused numerous male patients under anesthesia by doing non-consensual genital exams on them. There is absolutely no reason for an ENT doctor to do genital exams on patients.
Now we will talk about chaperones such as nurses for patients undergoing intimate procedures.
Many people falsely assume that patients will be protected from sexual abuse and wrongdoing by a doctor if a nurse or medical assistant is present. But is this really true? Many male doctors will have a nurse or assistant present for intimate exams such as breast, pelvic exams, and pap smears. The chaperone is the doctor's employee, so she looks out for him, and she will often defend him even when he does something wrong. Keep in mind that the nurse or assistant is there to protect the doctor and is rarely on the patient's side. There are times a nurse or assistant may know that the doctor is doing something wrong, but she may be afraid to expose his criminal activities for fear of being fired or facing discrimination in the workplace. Even in cases where a state medical board mandates a chaperone as a result of a doctor's prior sexual misconduct, the chaperone is not directed to intervene if misconduct occurs, but only to observe and report to the medical board. This is not good because sexual abuse should be prevented in the first place. Nearly half of all doctors sanctioned for sexual misconduct still practice. Even doctors who lose their licenses for sexual misconduct can often get them reinstated after a year or two. It's hard to collect the evidence to support one's suspicions, and without evidence, victims feel powerless. It usually takes many years for a male doctor to be arrested for wrongdoing, since doctors have so much power in our society. Important facts about chaperones to keep in mind. Number 1. A nurse assistant cannot help to chaperone a doctor's mind. She cannot control his lustful thoughts, as he does intimate examinations on women. Check out the Time and Tide article, a publication by American Medical Association, about a doctor who confessed he had lustful thoughts toward a woman as he did a pelvic exam on her, at www.patientmodesty.org/avoidmaledocs.aspx. Look at all the sexual misconduct cases involving male doctors in the news at www.sexualmisconductbydoctors.com. Number 2. A nurse assistant rarely will advocate for your wishes. Number 3. A nurse assistant rarely helps to prevent sexual abuse. Abuse usually happens so quickly. Number 4. Doctors are able to get away with more unnecessary invasive exams if a nurse or assistant is present without getting in trouble. Why would the presence of a nurse make acceptable any exam that bears no relevance to the patient's presenting concern? Here are 2 examples to consider. Number 1. Breast and external genital exams performed by an endocrinologist on a woman presenting for suspected hyperaldosteronism would be inappropriate with or without the presence of a nurse. Number 2. Breast exam performed by a doctor on a lady who has jaw pain.
For those who are interested in learning about modesty in medical settings from a biblical perspective, it is recommended that you check out this website. Make sure you check out the article, Are Male Gynecologists Biblical?
Please share our website, patientmodesty.org, with your family and friends. Patient modesty is an important issue that is rarely discussed.